Okay, so we're going to talk about a couple of clinical approaches that we've been using at my office, Boston Sports and Biologics, in regards to protein-rich PRP with A2M and monocyte-rich PRP using EMSITE's new devices. So first, my disclosure, I am on the clinical advisory board for EMSITE and have been since the summer. Dr. Stevens already introduced a little bit about my background. But I was happy to come back to Boston, join Walter Sussman at Boston Sports and Biologics, and I've been there now for about over 2 years. The two patients I'll be talking about today, the first is a 40-year-old male with chronic medial knee pain, so an active guy, hockey player. He is a combination of moderate medial tibial-femoral chondromalacia and a complex medial meniscal tear. He's treated this off and on for a long time, over 10 years with different activity modifications, multiple corticosteroid injections, but no surgery, as he's never had mechanical symptoms and has been trying to avoid that. The second patient is a 60-year-old male, former collegiate football and semi-pro football player who's had chronic insertional Achilles tendinopathy for decades. He's treated with just about everything conservative, including shockwave therapy, multiple rounds of physical therapy. And then when I first saw him, we ended up doing a Haglund debridement with the ultrasonic 10x bone device. And he had a good deal of improvement after that, but he still had some lingering pain, especially when he tries to return to weightlifting. So he's looking for something else aside from surgery. So first we'll start with patient number one and knee osteoarthritis. And this is the usual treatment spectrum that I'm discussing with my patients and what their options are for these degenerative meniscal tears. His may have started acutely, but now it's in the presence of arthritis, and we can call it, and it's chronic, so we can call it a degenerative meniscus tear at this point. We're to the point now where he's considering orthobiologics or surgery. And so this is probably a little bit below most of the attendees here, but we just want to briefly say, what PRP is and then why these definitions may not hold weight anymore. From a definition standpoint, PRP is an autologous blood product with a platelet count above baseline levels. Now, the FDA defines that as a platelet level above 250,000 microliters. I mean, that's not platelet rich to me. That's almost just a normal platelet count. That's whole blood. So we now kind of expect that a platelet level should be 5 to 10 times the basal level for all PRP. And these concentrations are pretty easy to manipulate just based on the volume that you use. You can have a 50 times concentration if you concentrate it down to 1 cc, and you can have a 5 times if you're doing a higher volume. So really what matters is the dose. And what is that dose? What are we aiming for? Well, in 2021, Bonsall showed that 10 billion platelets provided a clinical improvement over lower doses. And then a systematic review by Berrigan in 2024 tried to sort out, where those thresholds are. And when he looked at randomized control trials, I believe there were 32 of them, they concluded that the mean platelet dose in 28 randomized controlled trials with a positive outcome was 5.5 billion, whereas 3 RCTs with no positive difference had a mean platelet dose of 2.3 billion. So, since that study came out, we've all been, trying basically to have a minimum threshold of around 5 billion platelets. And there have been subsequent studies that show that, higher doses may be even more beneficial. So how do we get that dose? Let's do a little math. I don't expect you all to follow this, but if you screenshot it and look at it later, it might make some more sense. So a normal platelet count is anywhere from 150 to 450,000 platelets per microliter. And with an average platelet yield, depending on what device you get, the literature says most devices average around a 70% yield. Well, if you put those two things together and you take a 10 ml blood draw your max dose you're going to get is about 3 billion platelets, and you might get as low as 1 billion. If you triple that and you go up to 30 mLs, max dose with a 450,000 platelet count starting is still under 10 billion. So the only way you're going to get to that 10 billion dose is if you're using a 60 ml and you have, a higher than average platelet count, over 300,000. And I don't know about you guys, but in our clinic, we tend to see more people running 150 to 300 than above 300,000. So my advice, if you don't have a platelet counter in your clinic, we're doing it pre and post for all of our patients, then you should be using at least a system that you can draw 120 cc's. A review this year by Corsini recommended a minimum dose of 4 billion, but an optimal dose of 10 billion for knee osteoarthritis. And they also reviewed studies showed a similar pattern for tendinopathies, showing better outcomes with rotator cuffs and tennis elbows and other chronic tendinopathies if over 6 billion platelets, or if 6 billion was the threshold. So there was also some preliminary data suggesting that peripheral blood mononuclear cells may enhance efficacy. And this kind of leads us to, what else can we do to improve our PRP outcomes? So recently, monocytes have been something that has come up. Now, the problem with isolating monocytes is that we need to, at the same time, minimize neutrophils. These two things are working against each other, whereas monocytes may increase reparative properties and assist in immune modulation, as Dr. Stevens mentioned, and increase tissue regeneration. Neutrophils will do the opposite. They're inflammatory, catabolic, releasing cytokines and enzymes detrimental to healing. Now, this is theoretical and lab-based, and there are very few, if I don't know of any actual clinical randomized control trials looking at OA and tendinopathy in regards to monocyte-rich PRP. So those studies still need to be done. And in terms of alpha-2 macroglobulin, one of our viewers will recognize this image. It's from his paper. A2M is a serum protease inhibitor that suppresses proteinases involved in osteoarthritis. So there have been in vitro studies showing A2M blocking these pathways and leading to reduced inflammation. We just don't have the clinical studies showing that this then results in a better outcome for a leukocyte poor PRP product compared to a non-monocyte rich leukocyte poor PRP. So clinical trials are still necessary. So here's our patient, and I'm just going to kind of scroll through this video a little bit. This is patient number 1 with knee osteoarthritis. And first thing I'm doing, and again, feel free to ask questions, leave them in the chat box. This is not the only way to do PRP. This is just how we do it. First thing we've done is sterilize his knee. So you can see the ChloraPrep color, and this is sterile gel on his knee. I like to use a supralateral approach. Some people out there are injecting directly into meniscus. I haven't found a need to do that, especially in a degenerative kind of complex meniscal tear. I don't need to get it into one spot. I just need to get it into the whole joint. So we've already consented this patient. It's obvious he has an effusion in his suprapatellar recess. This is in long axis with the quad tendon over the top, patella on the right. Suprapatellar recess is the large anechoic space in between the two fat pads. Now, since I know I'm going to be causing more of an effusion over the next 3 days with this PRP, I want to get whatever extra fluid is in there out. So the first thing I'm going to do is just anesthetize him and put most of the anesthetic into the soft tissues. Now, there's some debate about how much should we be anesthetizing with PRP or not. Well, since I'm going to be moving through here with an 18 gauge needle to draw off that fluid, I'm going to anesthetize him. And I'm not going to put too much into that space. I'm going to put about 2 cc's total into the joint space and then pull back. and mostly anesthetize the soft tissues. There are studies that show as long as you keep a low ratio of an anesthetic to PRP, you're doing no harm and not going to change any clinical outcomes, even though there are in vitro studies showing that anesthetic does inhibit platelet activation. So try not to flood the area with excess, and I don't use 2% lidocaine or Marcaine or bupivacaine, anything extra chondrotoxic like that. So next, we're going to put the 18 gauge in, draw off that fluid. And finally, we're going to inject our PRP product. So this looks a little more red, and it's than some of our true leukocyte poor. We get a little more red blood cells when we take that layer of monocytes, and I think someone else might be talking about that later. But there's 8 cc's in that syringe, so 4 of those cc's are the PRP, and another 4 cc's in a 1-to-1 ratio are the concentrated platelet poor plasma that we put through the A2M filter. And that won't, if you guys try to inject that through a 25 gauge, it's not going to go, it's too thick. So I'm usually using at least a 22 gauge at minimum, sometimes 20 to inject that. So from this view, the suprapatellar recess is here. This is now in short axis on the knee, so quad tendon is above in short axis. I always recommend, switching between short and long to confirm your placements. Now you can see needle here, fluids being injected and spreading proximally and distally in the suprapatellar recess. And then we're cleaning off his knee, applying a Band-Aid. And, from a post-op protocol, my main restriction is telling patients, no hot tubs, no pools, no bathtubs, no infection risks until, 48 hours is over and that poke hole is closed. From an activity standpoint, I'm not as restrictive as some people. I know some people want to offload that knee for a period of time or avoid activity. I let people kind of ramp up their activity as tolerated, as long as it doesn't include running, jumping, or deep heavy squats in the first 2 weeks. But getting on a stationary bike, walking as long as they want, fine for me. And then the next thing I do is, I'll go over the results of the PRP analysis. So that's what I'm doing with him here. We're going over just how many platelets were obtained in those 4 cc's of PRP, and also then discussing with him why we're using a monocyte rich technique in this procedure. And I think the take home points for the knee are, the dose matters. So you should either measure it or use at least a system where you're getting 120 mLs. And then from a future standpoint, consider these systems that can allow you to either, obtain A2M and protein-rich PRP or monocyte-rich systems. And we'll see how they play out, as we get more clinical data. Next, we'll talk about Achilles tendinopathy. And this is a talk I gave about two years ago now. I think it was 90 minutes, and we talked about Achilles tendinopathy and everything you can do for it. So, I'm going to talk to you now for 10 minutes, and it's going to be really, really pared down. So if you want to see a longer talk, you can join IOF and go take a look at that. But we're really going to focus in here on just PRP for Achilles. And if you look at the title of this talk, I called it the Achilles heel of orthobiologics, because as you'll see, the data really doesn't support, historical data doesn't support using PRP or any biologic in the US for Achilles tendinopathy. And we'll talk about then why we still tried it for this patient. So here's your treatment spectrum of options for patients with Achilles tendinopathy. This is not specific to insertional or mid-substance. This can pertain to both. And our patient has, like I said, tried everything on the conservative side. And then in the alternative side, I can't remember if he tried steroid. I would never recommend steroid around an Achilles tendon. But he has had an ultrasonic tenotomy and Haglund debridement, which gave him about 60% relief. And he's trying to see if we can get him closer to 90. So here are the most recent systematic reviews and meta-analyses on PRP for Achilles tendinopathy. Now you can notice a few things. None of these are for insertional tendinopathy, and none of them show a benefit. A lot of these cite the same randomized control trials, and you'll see a few of them come up frequently, especially in the more recent ones. In the more recent ones, the RCTs that get cited frequently are Kearney's study from JAMA in 2021 and Thurman's study in 2023. Now, the problem with systematic reviews is if you don't have good RCTs, you're not going to get a good systematic review. And not that these are, were poorly done. I think they just did things that we wouldn't do in the orthobiologic sphere. So if we look at Kearney's study, for one, they didn't use ultrasound guidance. And we'll talk about why not using ultrasound guidance, and who knows where that PRP is going and what kind of tendinopathy they're actually dealing with, because not all tendinopathy is the same. Number two, they injected 5 mLs of 2% lidocaine. Now, when I'm injecting in and around a tendon, I might be injecting 2 mLs of 1% lidocaine. So they're injecting 5 times as much lidocaine in there. And their blood draw was only 9 mLs of whole blood, which is very low. If we go back to our, what can you get from a 10 cc blood draw, you're going to get somewhere between 1 and 3 billion platelets. And so you're taking a low dose PRP injection, you're flooding it with 2% lidocaine, and you're injecting it without ultrasound guidance. I wouldn't expect that to outperform a sham injection. And now we have an N of 240 in those systematic reviews and meta-analyses. And that's going to probably, that will definitely skew the conclusions of those meta-analyses. Thurman's study also showed no difference. But again, they only used a 10 ml blood draw. So I think we need to have better RCTs and we need to have better systematic reviews. So why, treat this patient with PRP? Well, Corsini's study did touch on that. There have been similar patterns seen for tendinopathies that if you use a higher dose of 6 billion, you can get better results. And maybe, using mononuclear cells, monocytes, A2M, maybe we can get a better result. I will say that, and this, I forgot to mention this with the knee osteoarthritis. When I moved to Boston, joined Boston Sports and Biologics, and went from University of Washington to here, I had never used A2M, and I didn't really, there's no clinical studies, so I wasn't jumping to do that. But we use a system called Data Biologics to track all our outcomes. And, just looking at when I was using A2M and when Walter was using it, I could see that, comparing our regular PRP to our A2M PRP, patients were getting better about 20% faster, kind of at all time points. So they were just, they were reaching a similar endpoint at 6 months, but they were getting there faster in the A2M group. So I started using it, and I haven't really stopped for about the last year and a half. And this is what I meant by not all tendinopathy is the same. These are very different things that require different treatments. This partial tear in the upper left, there's a problem with that is that when you inject it, a lot of that PRP is going to spill out into the Kager's fat pad just because of the deeper surface fiber tear. The diffuse tendinopathy in the middle, that's probably better treated with maybe 10x, maybe PRP might help too, but it's just a thickened tendon. On the bottom left, we do see some intrasubstance tearing there. That's probably, in my opinion, the ones that do best with PRP. And then these intrasubstance calcifications and insertional calcifications, those usually we're not injecting with PRP. So I don't know, if you're not looking with ultrasound and you're just sticking the needle in there injecting, I don't know where the PRP is going. So here's our patient. And the first thing I'm doing is I'm just going to scan his insertional tendon. And you can see, and I always tell people, after a Haglund bony debridement with 10x, that this area kind of looks like a debris field. So this used to be a large protruding kind of triangular area that rubbed against the undersurface of this tendon. Now it's angled at about 30 degrees downwards here with this irregular slope. And you'll see probably some intrasubstance calcifications around that from the debridement. But the thing that jumps out first are these partial tears of the undersurface. We'll see other things, and we'll see how that tear kind of spreads into the more central tendon later here, this area of tendinopathy. Now, whenever somebody has a large Haglund's, we're usually recommending to at least try to shave that Haglund's down a bit before we go in there with PRP, because if we fix the tendon but we don't fix the bone, that tendon tear is just going to come right back. So first thing I'm going to do is anesthetize the patient. Now, if I really wanted to avoid using any anesthetic, could do a tibial nerve block plus a sural nerve block, but like I said, I'm not as concerned with a little bit of anesthetic, at least especially when you're using a high dose PRP. The one thing we're noticing here as we're injecting is that this is what happens with the tendinopathic tendon, is that flow pattern spreads very easily, and you can see some intrasubstance tears open up. That shouldn't open up so easily. I'm not pushing hard. I'm just basically tapping with my thumb to try to find spots of little resistance. Now, on the other hand, I did a 19-year-old patellar tendon today, and I have to push really hard just to get that anesthetic to flow into the tendon. It's just very tight without much space. So this is kind of the classic thing you'll see with these older tendinopathic tendons. So once he's anesthetized, we'll get our PRP A2M product, and you can see this is only 4 cc's. Again, mixed at a 1-to-1 ratio, so 2 cc's of PRP and 2 cc's of the A2M. I think the whole video will be on YouTube. I'm not sure, but that's up to MSite. So again, using sterile gel, we have Tegaderm and a sterile Coban wrap. I like the sterile Coban wrap because it gives me a really good grip on the probe for some of my longer procedures. Now you can see the PRP entering. So I'm not pushing hard. I'm doing this with a really light thumb. And the reason for that is I don't want to distend that tear more than I have to. I want to, move that needle around, let it fill up, and see how much I can get in. Now, probably only going to get a cc or two into that tear, and then have to redirect my needle and go find those other small intrasubstance tears we were seeing with the anesthetic. And so you'll see me pull back here and then redirect shortly, more superficially. And this is probably the initial kind of intrasubstance tear that we saw with the anesthetic. So once all that's in there, the post-op protocol for Achilles tendons and other tendons in general is more guarded, uh, more conservative than with joints, at least in my clinic. Uh, Again, same infection risk, so no submerging the ankle. Showering's okay. From a pain management perspective, we use Tylenol plus Jernavix, which is a new medication that was FDA approved last January. If you guys haven't heard of it, look it up. I think it's a great option for orthobiologic. And the reason for that is it's not an NSAID, it's also not an opiate. So you can use it and patients can work on it while they're taking it. They can drive while they're taking it. It doesn't cross the blood-brain barrier. Because I don't want my patients on NSAIDs for 2 weeks after or 2 weeks before this procedure. They go in a tall walking boot for a week and then wean out after a week and hopefully are starting their PT by 2 weeks. Gradually going from, as you all know, isometric, concentric to eccentrics, and then finally plyos. So, for this, I think, we still have to trust the literature a little bit. There's too much literature out there that shows no improvement. And so when I talk to patients about biologics and Achilles, I'd let them know that. But I also let them know I think a lot of those studies were done, not ideally, not under the ideal conditions. And I think there's a better way of doing it. And I've seen plenty of patients do really well. So I tell them that and then, let them make the decision. But still, they should be focused on the conservative stuff first. And that means physical therapy. And then hopefully, using A2M and monocyte-rich formulations will lead to better results in the future. We'll see.
All right, thank you so much, Dr. Latzka. So we have a few questions already. I think maybe we can take one right now really quickly.
Sure.
And then so one of our questions is when to use A2M and monocyte rich PRP, like for which conditions and for what patients, that sort of thing.
Yeah, I think the one of the things is that if you're using A2M, it's going to cost a little bit more. You're going to have to pay for the filter, so you're going to have to factor that into your uh, discussion with the patient. But for me, I this is just kind of how we've done it in our clinic. We used to see our younger patients doing better with PRP than our older patients, and so in my older patients, I'm using A2M and I'm pretty much just recommending it to all of them because it kind of has narrowed that gap and we've seen them kind of catch up to the younger patients a little bit. Uh, the younger patients, they do well without it. So I'm not, making that recommendation or if they want to do it, fine. But I usually tell them, if you've got mild arthritis or a small partial meniscus tear or mild tendinopathy, small intrasubstance rotator cuff tear, is going to do pretty well. You're young. But in my older patients, I'm definitely recommending A2M. Larger tendon tears, I'm definitely recommending A2M. Not high grade tears. I mean, a high grade tear still might require a little more of a substance, either an MFAT or BMAC or surgery. But for my that's kind of how I think about it. And I don't think you have, in terms of monocyte riches, if you have access to the M-Site new kit, you could do that for all of your. That doesn't add any cost. You just have to know how to do it. So I think why get those neutrophils? I don't want them in the product anymore, and I still want to get these high dose PRP counts. So I'm pretty much going to use that for all of my. I think unless there's a study showing me that it's doing some harm, which I can't imagine, that's just going to be probably my new standard protocol.
Okay.
The
Thank
A2M is the
you.
more optional thing.